My name is Brody, and I'd like to welcome you to Did You Know, a podcast that explores issues in research, practice, and leadership. I am a physical therapist at the University of Wisconsin Science Drive Medical Center and a professor in the PhD program in health sciences at Rocky Mountain University. I am also a faculty member in the orthopedic residency here at the University of Wisconsin, and we are sisters.
She didn't say who was older or younger, so you can just figure that out on your own if you want. Hi, everybody. My name is Jill Thein-Nissenbaum, and I'm a professor in the Department of Family Medicine and Community Health at the University of Wisconsin. I teach in the physical therapy program. I teach the orthopedics courses and a sports PT elective. I am also board certified in sports, as you are. Mm-hmm. And my clinic appointment is with UW Athletics. I'm in my 16th season providing care for the UW athletes. So Lori and I are both very excited to be here, and we're very excited to talk about a very interesting topic, something that I never thought when I graduated from physical therapy school, this would be something we would be doing as clinicians.
I know. So did you know that the Imaging Special Interest Group of APTA Orthopaedics has an imaging education manual for DPT programs available on the website? It's currently undergoing revision, but there will be an improved version that's available for people to download and use. And there's all kinds of tutorials and other kinds of information on that SIG website. So you can access that and find out all kinds of information on imaging, the topic of our discussion today. And Jill, do you know how many jurisdictions currently allow imaging privileges for PTs?
I do, and hopefully this number will continue to rise, but I believe right now it's 11.
Okay, what are we doing here today?
So today we are going to talk about a recently published paper in the Journal of Manual and Manipulative Therapy. It was published in February of this year, and it looked exactly at the ordering of diagnostic imaging by physical therapists, and it was a multi-center approach. They wanted to look at the utilization, if things were reimbursed, things like that. So we have two of the authors with us today. So the first one we have here is Evan Nelson. Hi, Evan.
Hi, thanks for having me on the show.
You are excited. We're excited you're here, and it's a pleasure to have you with us. Evan is an orthopedic certified specialist and an associate professor at the University of Wisconsin, where he also teaches the DPT students. He conducts some clinical research, and he practices in an orthopedic clinic. He is also the tallest guest we've ever had on the podcast.
It doesn't show up so well on Zoom.
It doesn't show up very well on Zoom, but that's okay. Yeah. Your diagnostic imaging research has all been done real world clinical settings, and your results, as we're going to talk about, really push the PT signed imaging referrals closer to a routine kind of what we think of as common practice.
Right.
So we're happy to have you here, Evan.
Yep. And one of the other authors is Scott Tauferner, an expert clinician in the outpatient spine physical therapy department at the University of Wisconsin Hospital and Clinics. I believe, and correct me if I'm wrong, Scott, but he holds the record for the largest muskie caught by anyone on the podcast. Is this true?
That is true. And thank you for having me. And I challenge anybody to match that.
And how big was that muskie?
49 and a half, half inch shy of
centimeters?
Inches.
Oh, yes. Let's get that out here. Let's get that out there for sure.
So he's an instructor in the orthopedic residency imaging and the lumbar spine units in the residency program. And he is a strong advocate for PT signed imaging referrals. And we should say there were a number of other authors also on this paper. And the lead author, I believe, is going to be interviewed on a different podcast, but one that isn't maybe as much fun as ours is going to be, because Evan's on vacation. So he's having a great time.
Correct.
Super happy to take away from his vacation time to be here with us today
to discuss imaging. So Evan, let's start with you. Can you tell us a little bit about the history of imaging ordering privileges for physical therapists? How did this all come about?
Yeah, well, physical therapy or physical therapists signing referrals for imaging is not new at all. It started in the U.S. military. They've been doing it there for decades, like so long that it's a giant nothing burger when they talk about signing referrals for imaging of all types. Outside the military, this is still like kind of a hot and emerging and topic of big advocacy. So the U.S. military had such great success with it. Then it shifted over into the non-military settings, really in tandem with direct access. And so different than you, where you described having sort of no idea of this happening when you were graduating from physical therapy school. As I graduated in the early waves of DPT education, this type of topic was something that was being talked about.
Mhm.
And
Right. So when we
Yeah.
graduated from PT school, we were still getting all of our notes on stone tablets. So
Mhm.
let's just get that out there.
Exactly.
So, and it was
Exactly.
a physician's referral with everything laid
yep,
out.
Yep, exactly.
So you're really hitting a different wave.
Yeah. And so where we've come with this is we have had the good fortune of being on the leading edge of this here in Wisconsin. One of our colleagues and mentors, Dr. Bill Boysonow, was a champion for this topic. And the history in Wisconsin is actually a little bit unique in that we had an interpretation of rule that allowed physical therapists to sign imaging referrals because there was no law that prohibited it. Then there was a change in the Radiologist Practice Act, the Radiologist Technicians Practice Act, that prohibited them from accepting our referrals.
Oh.
So, yeah. So then we couldn't do it even though we had the same clinical skill set, and we had been doing it successfully for years. So then we had to advocate to get our law changed to explicitly say that we could, as physical therapists, sign referrals for imaging. And in Wisconsin, we're radiographs only. So we can refer for radiographs if someone's qualified by meeting one of 4 criteria, meaning they've graduated with a doctor of physical therapy degree, graduated from a an accredited residency or fellowship program, or have a board certified clinical specialist in one physical therapy area, or then the 4th is completed a formal continuing education program that has demonstrated physician involvement. Those are the 4 criteria for someone to be legally authorized to do it in Wisconsin.
Right. You know, it's interesting. I believe also on the special interest group website, there's information on how to advocate for legislation. So you talked a lot about Wisconsin and what they did to advocate and work with the radiologist, interest groups, as well as the legislators to get that passed. So there is information there on that.
Right.
So, Scott, why did you think it was important to study implementation of diagnostic imaging? Who was your primary audience, or who were you trying to reach by doing this study?
Yeah, this all started really just with more of an internal audit. How well are we doing, and a curiosity of how much are we ordering. So it was probably 2018 or so, I think, that Evan and I were talking and came up with the idea to just review, really just to see how well we were doing. It was a year or two, maybe it was finished 3 years after we had gotten the legal authority to image again. But it really just started with that curiosity, and it really has, it grew once we got the data. And then it's, blossomed into this paper. But really just that initial curiosity to make sure that we were ordering appropriately, and how often were we actually utilizing this privilege.
So this was a multi-site study. So you said you started off just with curiosity about how those of us in the University of Wisconsin hospital system were utilizing the imaging privileges. How did this expand to a multi-site, especially for people who may want to think about, I want to start a research project, or I'm curious about this, but my sample's too small. How do you go about how did that go?
Yeah. How did you find your friends at the other institutions?
I think that's a great question. And, looking back on it, it's hitting, I guess, the right points at the right time. It kind of fell together. But the original study that Evan and I did with our UW data involved 100 cases, and we submitted to present at CSM and got a platform. At that platform in the audience were Dr. Hazel, Dr. Chuck Hazel, and also Bruno Steiner. And then also it happened to be Lance Mabry was in the audience as well. And of course, Evan was there as well. So after the presentation, I was approached by Dr. Hazel, and he had interest in our data and asked if we'd be willing to, expand on it and maybe collaborate. And then that led to an email chain, which led to a year or two of writing a paper.
And you've been on our podcast right now.
Yeah, and now a podcast.
Does it get any bigger than this, Scott? We never would have planned this.
This is the pinnacle.
Yes,
I'm sure.
Exactly.
But
Other than the muskie.
Other than the muskie,
Yeah.
I don't know. We'll have to talk
Yeah.
to Scott how this compares with the muskie.
Yeah.
But it's such a good point of this networking at Combined Sections meeting and you sharing your information at that meeting, and then all of a sudden it blossoms into this. So now with this paper in particular, there were 3 different sites, and they were all a little different. They're a little different, and as Evan mentioned earlier, in Wisconsin, we can only order radiographs, but the 2 other facilities can order things beyond radiographs, MR, CT, DEXA scans, things like that. So how did you make sure that all of the physical therapists had the same basic training? Did you go by those 4 criteria that Evan mentioned earlier? Was there any additional training they had to have at all? Or as long as they met one of those 4 criteria, was that adequate?
You can go
So
ahead.
we actually took the approach of, if the state and employing organization allowed that person, whatever criteria they established for their own internal quality and competency standards, if that physical therapist is allowed to sign a referral in their daily work, then they were in the study.
Okay.
We really looked at the instances where a physical therapist signed the referral or signed the order for imaging. That was the driver of our show. We actually didn't want to over control on the types of training. We wanted to catch real people doing real work with real patients.
Okay. Go ahead.
So let's talk a little bit about what you found.
Right.
Because
Drum
everyone's
roll.
waiting. So
Just
tell
the
us,
highlight.
let's start out a little bit about utilization. So can you give us some of the details about the utilization of imaging by physical therapists at these different sites or across the board?
Yeah, so in terms of utilization, what we found was really quite an extremely low rate of utilization. But interestingly enough, similar rates of utilization across our 3 sites that are in 3 different states, all with retrospective data. So I thought that was quite interesting. Utilization rates were as high as 3.5%, and ours were at just about 0.89%. So anywhere from 35 per 1,000 evaluations to 9 per 1,000 evaluations. So it was, again, interesting that across sites, we really have a similar low utilization rate and appropriateness hovering right around that 90%.
So let's talk about that appropriateness, because I think this was one of the concerns that maybe other healthcare professionals had with physical therapists having the opportunity to sign referrals, was it would be overutilized, it wouldn't be inappropriate, things like that. So I believe there's some standards that are put forth, Evan, that kind of give you the recommendations of the appropriateness or inappropriateness of the referral. So can you talk a little bit about kind of those standards, and then we'll talk about back to what Scott said about how perfect we are.
Yeah, so the standards are set forth by the American College of Radiology. So they're the ACR appropriateness criteria is what they're commonly referred to. And it's really on a quest to figure out if an image that's obtained was appropriate or not to get in the first place. And we use these standards when evaluating our own referrals inside the cases when that occurred in this study. But these appropriateness criteria are not PT specific. They apply to any healthcare provider who orders any image at any time. So this is the standard by which the radiologists have determined, is this study appropriate or not? So we held ourselves to that same measuring stick. And we were shocked with how high the appropriateness level was. Shocked.
So can we do a multiple choice question? Because we always think that people in education and our listeners should have a chance to answer a multiple choice question.
Right.
Yeah.
Okay. So according to the findings, what percentage of imaging referrals signed by physical therapists across the 3 institutions were considered appropriate? A, 75%, B, 83%, C, 91%, and D, 95%.
Scott, what's the winner?
It's going to be 91%.
Always C.
It's amazing.
Always C.
But
Yep.
that's an A. That's A level quality.
Right.
So physical therapists they're meeting this criteria. Their standards are very high. They're very appropriate, which is really great findings that we are not overutilizing, as Scott referred to earlier.
Well, and I think going back to one of the reasons for doing this is there's this question of overutilization, and people don't want yet another provider ordering imaging because they're already overutilized. How do we compare to other non-physician providers? And how many of those patients, if you know the answer to this, that came to PT and had images ordered, like how many, are there other patients who already had images that were ordered by somebody else before they came to PT? Like, before they go to the physician assistant, perhaps no one has looked at that. So they're the first contact, they order imaging, but sometimes in PT, they've already had images ordered. So can you sort some of those things out for us?
Yeah, I'll address a couple of things that are inside the boundaries of the research and are therefore generalizable findings. But Scott did the really hard work and hand reviewed all of the charts from the University of Wisconsin. So he's got some excellent stories from that labor of love that he put into this project. But inside our story at UW, we had 2 3-year chunks. So the first 3-year chunk included 100 instances of referral. And that's what produced the CSM abstract and the platform that Scott presented that ultimately led to this multi-site study. But that was aging a little bit, and that ended in 2020, and this paper is coming out now. So Scott then went and looked at an additional 3-year window of time and the patients in there. And we went from 100 episodes where a PT signed a referral to 300 episodes in the second 3 years.
Wow.
And so we dump in a whole bunch of new people, new people that have come into the system, newly employed, transferred, of all different criteria too. So it's not like they were all new graduates who entered. They came to this system, passed through what is required to be eligible to do it, and started referring. And when we dumped in these new people that were relatively new to the system, the appropriateness in our internal subset of data from UW went up, not down. It drew the whole thing up. It was impressive.
Wow, that's fantastic.
How do we compare to other kind of allied healthcare professions? So physician assistants,
nurse practitioners,
other kind of professionals that can refer to radiology. Is our appropriateness similar to theirs, better, worse? Where do we sit with that, Scott? Do you know?
Yeah, I mean, we have some ballpark figures, and really our co-author, Stephen Carha out of St. Luke's, he has some data directly from their hospital on this. And as far as I know, that's the best data I've seen. But roughly anywhere from 50 to 75% appropriateness amongst general practice physicians being on maybe the lower end, and then specialty providers, orthopedic specialty providers being a little more around the 70%. But again, we're at 91, and that's the best data I'm aware of yet.
That's as good. That's as good as a 49.5-inch muskie, isn't it? That's amazing.
So when you went back and looked at this data, how did we do in terms of reimbursement? Did we have issues with third-party payers reimbursing for these images?
You want to take it, Emma, or you want me to? We don't have any instances of denial of payment from any ordered images by physical therapists, imaging ordered.
And that's across all the institutions, not just University of Wisconsin.
Correct.
Correct. And so we have 3 different institutions that have no
Right.
business relationship in 3 different geographic regions. So that means 3 different payer mixes.
Right.
And we have no instances of denial.
That's
So
amazing.
Yeah.
we hear about clinicians saying, I tried it, it didn't get covered. One of the things that we have to acknowledge is that there are rules and regulations and requirements before this gets reimbursed by insurance. Those are true for everybody, regardless of the credential. So if you as a PT sign it, but you don't follow the rules that that insurance payer sets, it doesn't matter if your credential is PT or MD or nurse practitioner, whoever orders it needs to follow that particular payer's rules. That can get heavily complicated. We do have some needs to expand this so that we are viewed as qualified payers for Medicare, Medicaid.
Sure.
We're just not qualified providers. So those are immediately not covered if we order for those beneficiaries.
So Wisconsin has some fairly specific criteria to be able to sign these imaging orders. Can you talk a little bit about what's required? Like, do you have to have a DPT? And I know Wisconsin is a special case, but you also did a multi-site study with other facilities. Can you talk a little bit about what training they required and what each of you thinks should be the requirement? Is this an entry level? Didn't mean to toss you that, but is this an entry level skill? Should you be able to come out and order imaging, and what kinds of images?
Yeah. So the state requirements for Pennsylvania and in Washington, D.C., the District of Columbia, are less restrictive than Wisconsin's. So when you have the credential, then you can do it. Now, each of the sites have some competencies and some training that's required to be eligible inside their organizations. Those are really quality standards. And I think what we've learned, both Scott and I coming from the same organization that does also have some sort of internal training, is that there's a lot of system and process nuance. And to have some training in that, mostly to enhance physical therapists' belief and confidence that when they do this, they'll do it well, that can be a really good thing. Physical therapists graduate with the ability to make the appropriate clinical decisions about, does a patient need an image or not, and which type of imaging should they get. So that is an entry-level skill. And we have some good information that is being taught and being taught more frequently now than it was in the past. So that's the clinical decision is definitely an entry-level skill, in my opinion. But what you lack then is the where in your EMR interface do you need to go to click that button, and when you click it, what's the next screen, and how do you make sure? And then once you've clicked all the buttons in your EMR and you're pretty sure you've signed the right order, then where do you tell this patient to go wait, or what to do next in order to get this image? So those are the institutional specific process knowledge components that would really be helpful if you have some internal training to address those process knowledge that are going to be different from place to place and organization to organization.
So Scott, from your perspective, as someone who works with students, mentoring, working in the orthopedic residency, what's the skill set you see of people coming in? Do you feel like the students who are coming in are prepared to do that?
Yeah, I think, like Evan said, they certainly have the skill set to recognize the need. And then the other part would be, what images do you order? So it's recognizing the need. I think our entry-level providers certainly have that. And whether that be the need at evaluation and, is it looking for a fracture, or is this a person not responding and we need imaging for a little bit different reason than a fracture? So yes, they have those skills. The hard part, or the stumbling part, is when do you and how do you place that order? It's more, like you say, the mechanics of it. It's not the decision making.
Got it. So Scott, I'm really curious how this has impacted your clinical practice, because to me, this sounds really sexy. Like, this is really cool. We can order imaging, da, 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 da. Yet we found that physical therapists are extremely appropriate in this, and their utilization rate is very low, appropriate. Can you talk a little bit or give us a couple examples of how you decided this person needs some imaging, how it changed their course of care, or how you manage the patient? I think people would just be really curious to hear it kind of put into action.
Yeah, I think there was an interesting case that was brought up in the COVID days when we were working from home and through video, and treating a younger lady in her 50s.
Good. Thank you. I love that.
With some hip pain and low back pain, and trying to figure that out through a video assessment. And after doing 2 or 3 video assessments and the time moving on from COVID, I really requested that she come in and I see her. So sure, she could do some exercises, dynamic and static, that I was asking her to do, but it wasn't changing her pain. When she came in and I got my hands on her, her hip was terrible. And I was able to reflect back on some imaging, a CT scan that she had of her abdomen and pelvis from 8 or 9 years prior that showed maybe a little bit of osteophyte formation. But when I assessed her and she wasn't making progress with therapy over the course of 6 weeks, her hip really seemed like it was the main source of symptoms. We got radiographs for that. And she had a pretty severe progression of that arthritis encompassing the whole hip. So ultimately, she did very well with the new hip. After failing therapy.
So it really did justify, it really did change your course of care. You got the patient to the right provider, the right person to have the best outcome, I would say.
Right. And there were no red flags that said, oh, we need to do imaging immediately. You tried some conservative care. You tried the things that you thought should result in a positive outcome, and it didn't. So that's when, 6 weeks later, you say, we've done this. We're not heading the right direction. Now it's time to get more information so we can make sure we're heading the right direction.
Yeah.
Perfect.
Yeah. And then using that information and changing treatment strategies for a while. And, essentially she got about 3 to 4 months of therapy before we made the decision to discontinue. But, it was the in-person that changed it, and the ability to order those images.
Right.
Another case is a person comes in that I'm seeing for their back and they twisted their ankle the day before.
Right.
And now they've got tenderness on the base of their fifth, and I'm giving them standing exercises. Right. So even though I'm not seeing them for that, we order radiographs and find out, sure enough, there's a Jones fracture.
Right. Wow.
Yeah.
I'm surprised by how many times that happens, actually. So in the 596 episodes that we have where a physical therapist signed an imaging referral in this study, it's amazing how many times we just happen to be the next healthcare provider that the person sees after something happens in their life. They may have been referred or sought physical therapy care for something completely unrelated, but then they have a slip or a fall or something happens and they have a new need for healthcare that's of a higher priority at that moment. And we're the right people to help facilitate that process.
And you think about how much time, Scott, this is a perfect example, how much time you save that individual of not having to go to urgent care, of not having to contact their PCP, things like that. So then after you found out that this person had a Jones fracture, then continue along your story. Did you refer them to somebody, and did you put them in a boot? How did you manage them to give them their optimal kind of outcome?
Yeah, and I have the benefit of working in a clinic with an orthopedic clinic attached. So yes, we got imaging on site, changed weight bearing status to get imaging, gets imaging on site, ends up in a boot, but still weight bearing. After, then talking with the radiologist, I'm also on site, and before the radiologist is able to have time to read these, I'm able to see the images as soon as they're available, bring it to the attention of the radiologist, let them know that it's an acute injury, and then coordinate with our orthopedic sports department about care, because I can't care for the fracture on my own.
Right. Right. This is, I think one of the things that I didn't hear in the paper, but maybe it's there, is the cost savings, for
Right.
these examples of, not just
Exactly.
the patient's time, but now I have to make an appointment with my physician, or I have to go to urgent care,
Right.
or God forbid you go to the emergency room and
Right.
you're there for 12
Right.
hours with a fractured foot, or you wait 3 days and walk around on it and now you have a secondary problem. I think the cost savings to the healthcare system is huge. So is that your next research?
Lori, well, we've talked about it. We haven't taken action on it because the challenges of that in a real world healthcare system are, it would be a awesome question to answer. It's just incredibly complex to pull it off to get the answer to that question. But I agree with you completely. That is my highest desire for research, for this imaging related research, is like, for that one little work unit, what's the relative value for the therapist just taking the action when that patient is in front of them versus saying, go see somebody else, and then they have to go do that. And then what are the costs with that other provider for another office visit to ultimately arrive back at the same clinical decision you just made,
Right.
and just handling it.
Wow.
Right. So Scott, just to follow up with your patient who you identified needing imaging of their foot and they had their Jones fracture, how did your patient respond? Did you have to tell them, I can order imaging, I can do this for you? And how, tell us a little bit about, I'm sure they were thrilled to have all this done in basically, for lack of better terms, one-stop shopping. They didn't have to go through all these hoops that you talked about. Can you tell us a little bit about the patient response?
Yeah, that's a great question. Yeah, patients are very receptive to this and really trusting of the decision-making, in my experience, by myself and all of the physical therapists from the charts that I reviewed. They're appreciative of expedited care, not having to go elsewhere. I've only had positive response from it. And again, after we're ordering these images, there are also part of the state Practice Act is that we have to let somebody know. So we've also had extremely positive feedback from the primary care providers and referring providers when we let them know, I saw this person and we had to get imaging. So
great.
Patients are happy, and the doctors have only been positively responding in my experience.
Well, that's marvelous. I hope maybe somebody or some people listening to this podcast, Evan, jump in and reach out to you and Scott and say, hey, let's do that study. I think it would be a marvelous study to do.
Yeah, right.
So is there anything we haven't touched on that you guys want to share with us about this study or about physical therapists doing imaging in general?
One thing I know Scott's not going to want to share is the location where he
Caught
reeled
his
in that
muskie?
muskie. So we won't hold you to that.
Right.
Yeah, that's top secret stuff right there.
So if you could summarize, like in one sentence, what's the take home message? Each of you give me a one sentence. What should people take away from this research?
I'm not sure mine will be a sentence, but my big three are that physical therapists refer for imaging sparingly. We do it really well, and it's always been paid for when we follow the guidelines.
Wow, those are good.
Yeah, that pretty much says it all.
Right.
I don't know.
Scott, did he steal your thunder?
He did, but I would, without reiterating what Evan said, and again, I think those really are the top 3 points, but supporting yourself with colleagues that help reinforce progression of your practice in ordering and ability to order is also a really key player in this movement continuing to grow. So got to have support with your employer and your colleagues.
Yeah, and you were absolutely right. We are happy to meet with people. Scott and I have both done that individually and collaboratively to help other people who are interested in implementing it into their own practices, whether it's a small practice, maybe a PT-owned practice or solo practice, but also hospital systems. We worked with a number of people that are trying to advocate within their healthcare system. That's a bigger task, but it's been done effectively numerous times. About how to get this in those settings. And we really, really hope the reason all 3 organizations came together is that people would have this data when they go to advocate and their health systems, in their healthcare landscape, or all the way up at the state level to try to change their state law and policy regarding imaging by physical therapists.
Awesome. Well, that's, this information that you have, that paper that you have out there with all that data, that's just going to help move everything forward. So we're grateful for you guys and the rest of your team doing this research.
Really groundbreaking information that's really going to move the needle kind of a physical therapy, musculoskeletal physical therapy.
Exactly.
So we're very appreciative of that.
Do you want to hear one more joke on imaging? Want to hear a joke on imaging?
Yes, we do.
Okay.
Definitely.
Why don't radiographs ever get into arguments? Because they always see right through the issue.
Oh, nice.
So anyway, thanks to the two of you today for joining us. And Evan, I know you're on vacation, so thank you for jumping out of your beach shorts and into your headset. And thank you to everybody for joining us on this edition of Did You Know podcast. And next time we're going to be looking at
leadership, different ways or strategies or how you can get more involved from a leadership perspective, truly across your physical therapy career, not only as kind of an early career professional, but mid-career as well as late career, and how leadership kind of evolves and changes as we age in the profession.
Yep. And you can look at the two of these guys showing leadership here as well.
Exactly.
So in the meantime, keep asking questions and be curious. Have a great day.
Thank you.